Good evening,
or
yes,
whatever.
they can hear you well. So something is not.
Okay. See,
Okay.
everyone can hear me.
So the thing is,
Yep.
I want to ask. Hello.
Yes, we can hear you as well, Betty.
I seem to hear you well. Okay, I can hear you, but very faint. I mean, like very far. I want to ask you something.
Yep.
Now we have about 80 people.
Okay.
I think it is okay if we go live on Facebook, right? Even though we don't have 100
Sure.
people.
Sure.
It's okay, right?
Sure.
Okay.
I'm fully closed. You can go
I go
live
live
anytime.
first. I go live first, then we can start. Yeah.
Okay. All right. Okay, so before we start, maybe I just give a bit of how to say introduction. All right. So this session will be a very short presentation from me, and mainly I'm going to make it very interactive. Hopefully you guys will interact with me. If I interact with myself, then that is not interactive, but that is more schizophrenic. Alright. So how do you guys interact with me? I hope that you guys can type something in the comments. As I go along, I will ask a few questions. If you guys have any question, you all can ask in the chat as well, but not too many at one time, or else it jam up and I don't know which to answer first. Okay, so let's say someone asks a question and then I give me some time to answer that question before the second question come along, or maybe two questions and let me answer two questions first before the third question. Is that okay, guys? All right. So we get a very interactive bunch here.
It's a live chat.
So now we are waiting for Betty.
Yeah, waiting for me. Sorry, you hold on, because I think they changed the format.
Yep. Great, we have very interactive bunch here. I'm seeing a lot of okay.
More pages. Okay.
So now we are waiting for Betty to link us to the FB Live, right?
Oh, I am not sure how to do this now. Wait, let me check and see. How come I can't seem to...
Janganlah kacau.
Hold on, sorry. I'm so sorry.
Okay, the host will be Betty. You need to accept some of the people who want.
I cannot seem to go live.
Yeah, or maybe we can just focus on the Zoom first and later.
I can't seem to go live.
All right.
I can't seem to go live. So let me just go back again.
Yep.
And then I will go live to my news feed and see. And then after that, I will share it with.
Yes. And our SH has a very good suggestion. I think everyone should put on mute mode, and then so that we don't hear other noise. Yeah. And then if anything to ask, you can tap in the chat. I am seeing the chat as I share my screen. All right.
Okay.
All right. Maybe Betty, you can mute others as well.
Okay, hold on. I can go live on my page. So now I will go live on my page.
Okay.
And then I will then share. Okay, then I'll record. Record on this computer. Okay. Good evening, everybody.
Good evening.
Welcome back to another session of From Beating Hearts, a webinar with Dr. Low. This is, I think, our first session on obstetric and gynecology. More obstetric today, of course. And Happy New Year to all. Hopefully, we can put the 2020 behind us and have a better year. And then continue our continuous medical education and improving ourselves. And of course, let's hope that the vaccine will come about and make our life back to normal. I'm hopeful, and I'm sure all of you should be optimistic.
Yes?
Yeah, go ahead.
Okay. So good evening, everyone. So like I said, I repeat again what I mentioned just now before the new people are coming in. So this session is actually I'm making it a bit more interactive than the usual. Okay, and then the title that I have for everyone is Top 10 Reflex All Doctors Must Have in Obstetric Emergencies. Okay, and before I start, just a bit of introduction to myself. Okay. My name is Lo. My surname is Lo. My name is Kapin. Okay, I'm from Penang, but I'm not related to Jolo. Okay, although he's from Penang as well. And I'm working now in this hospital. Lo Guan Lai is a family hospital started by Dr. Lo Guan Lai, which is a GP. And then his son and his grandson, my colleagues, they are still working obstetric gynecologists. Okay, all right. So everyone can hear me? If you can hear me, type something in the comment. Yes. All right. And I'll proceed. Okay. So, great. Okay. So only Betty couldn't hear me well. Like everyone is hearing me fine now. All right. Okay. So, all right. So the first thing I want to tell you is actually the title that I want to have for this webinar is. These are the titles I want to put inside. Just that Betty said that, wow, this is too fancy. Maybe you guys won't understand what I want to portray, okay? But basically, this is what I want to tell you guys. This is not a session to tell you guys what you can get from your books. If I'm not telling you something that you can get from your books, you might as well spend the night reading your books and not listen to me, okay? What I'm going to tell you is this 10 reflex that you can try to learn up and practice and maybe go through to yourself that you need to know when you face with anything that is we consider as emergency in labor room or delivery, childbirth. Okay, so I want everyone to have all this mindset that all these things are unexpected, but make the unexpected becomes expected. It's like, okay, so we see this obstetric emergency called prolapse. All right, is it expected? Is it unexpected? It's supposed to be unexpected, but then it has become expected. You have a patient pregnant. If she comes, there's always a risk of cord prolapse, and then you don't go like so panicky that you really shit bricks and don't know what to do and you just freeze. Okay, so the worst thing is to freeze. Okay, all right. So the first question I'm going to ask the audience today is, who of you guys haven't been to the labor ward yet? Okay, who have been to labor ward? Please type in labor. Are you guys sleeping? All right. So everyone been to labor room. Okay, great. Okay, so quite a few. All right. How many we have here? Betty? Oh, now I can't hear Betty pula. Betty, do you mute yourself?
I don't know.
Right.
Can you hear me now?
Yeah, I can hear you now. All right. Okay. How many person we have here now? Oh, quite a lot.
We have 73.
Oh, 73. Great. That's a good number. All right. Now we try to go for 88. Okay. All right, which is a good number as well. Okay, so since a lot of people have been to labor room, so this would be a very interesting session for you guys because I can ask you guys some question and maybe you guys can also ask me back some question about what you have encountered. Okay, so there's a few key principles when you have emergency. There's no absolute right or wrong in emergency. The first thing you do is don't judge. Let's say you have emergency, someone do something, you don't say, oh, this one is wrong, this one is bad or anything. The only thing wrong is you know this emergency, you ran away. Okay? Running away is definitely wrong. But if you do something, I mean, you will be not 100% correct, okay? But at least there is some amount of correctness in that. But the main thing is don't judge. It's just like, later I'll tell you like, okay, maybe you have a shoulder dystocia. The first thing you must do is, the famous one is the McRobert, then the suprapubic pressure. So some person, suddenly they forgot about this McRobert, they just do suprapubic pressure. Is that wrong? That's not wrong, okay? So don't judge, alright? The second thing is, practice makes perfect. What it means by practice is like, you must encounter more emergency, then you get used to the emergency. So you will be like, okay, I've seen so many cord prolapse, so I know how to handle cord prolapse. But how to do that? Mainly is your time. Means that, let's say you are a junior doctor, you have a shift. This shift, you are only there, then you don't encounter any emergency. Then the other shift, you want to go back and rest. You go back and rest, and then if you think you have free time, you have extra time, you can come to visit labor room and just see, just in case there are emergency. But of course, if you're not your shift, please don't go to labor room and say, oh, I pray for emergency, I pray for emergency. Okay? Then people will really kill you, alright? Okay? So these are things that I would do last time when I was a junior doctor. I said, oh, I want to know more about emergency, so I just go there. And of course, you liaise with your friend. It's like, if you have any emergency or what, you can, call me up, or you can stand by and you can just help out. And then if let's say there's emergency, you can, maybe you're not the first person there, another person with you because you're not on duty. So at least you have something that you can help out, and then you can learn from that. Okay. The third thing is moderation is the key. Okay. Why I say the third thing is a key is because don't be a hero. Okay. Because later I will tell you about the first reflex that you must know. Okay. And then also second thing is don't be a pussy. Okay. Don't run away. If you know there's an emergency, don't run away. Stay with the patient. Okay. Yes.
Excuse me, I'd like to apologize for Dr. Lokapin's
language.
Sexist words.
Oh, alright, sorry.
Here.
Okay, sorry. Okay. Later I change.
A lot of women are not pussies.
Okay.
Yes.
No, I mean the men don't be a pussy. Okay.
Yes.
Okay. Alright. So the next thing I will tell you is, okay, so this talk is basically for junior doctors. What you can use when your senior doctors are busy. Example of busy is like, when some of your medical officers are in operation theatre, they are unable to attend to the patient, or they are busy with something else. Like for me, last time when I was a house officer, my MO would tell me, when you call me, you better have a good reason to call me. So it's like, well, okay. So whenever you have something to call your MO or medical officer, make sure that you have really good, you are really need to call him or her. Second thing is maybe you are in a land far away, meaning that when you guys are junior, sometimes when you become junior medical officer, you're posted to a district hospital, and then your main hospital is like half an hour, 1 hour, 2 hours, or 3 hours away, and you have an emergency. These are the things that you can do before you send the patient to the hospital. And third thing is when you encounter childbirth in public places. For instance, suddenly you're a doctor, you go to watch movie, and then your pregnant lady watch it together with you, and suddenly the movie very exciting, and then suddenly you need to deliver a baby. you need to conduct a delivery. Then suddenly there's some emergency some complication that you need to handle. So if you're a doctor, this is the thing that you need to know. What are the reflexes you need to be? Okay. For instance, if you're in cinema, airplane, or ferry, or Penang. Okay. So far, anyone has any experience of seeing a childbirth in public places? If you have, you type yes. If no, you say no. Anyone? No? No. Okay. So very, very lucky bunch of guys. All right. So have you guys? Anyone have handled emergency when your senior doctors are busy? Oh yes, there's someone said yes. Vidya Kushare.
She has? Oh my God.
Is this a yes to second question or yes to the first question?
Serena said yes.
Oh, ambulance. Okay.
Ambulance. Oh my God.
Okay. So was it uneventful or eventful? Vidya? Is it how to pronounce your name? Vidya? Uneventful. Okay, that's good. Usually 90% of time is uneventful. There won't be any complication. Alright, only sometimes 10%. Even 10% are mild complication, and then 1% will be the one with very heavy complication. Okay.
But Serena said that hers was eventful when she saw somebody.
Ah, okay. You want to type something to tell us what was
Maybe you can elaborate later. Yeah.
Oh, landed up in a scissor. So what was the emergency you have? Miss Serena can type in the comment section. Prolapse. Okay. So this is something that's expected as well. Alright. So later I will talk more about prolapse. Okay. Alright. So the first reflex that everyone must have is what? Do you guys want to guess what is the first reflex? Just now I've given you guys a very good tips. Calm. Alright. Okay, that is a reflex. Don't run away. Yes, excellent. Okay, Serena, you are right. It's call for help. Okay. So usually this is actually a basic thing. Even when I go for postgrad exam in our OSCE or anything, the first thing we do is to call for help. If you fail to call for help, you fail, because that is the first thing. Okay, so it's not just ask for help, you must shout for help. Okay, so for you guys who are some guys or ladies who are very, very polite, you all speak very soft. If you go to labor room, you must learn to project your voice. Okay, go in the room and shout help, help. Okay, you must practice in your dorm so that your voice is loud enough. Because honestly, I've seen many house officers before, and there are house officers that they just couldn't shout. Even when they shout, help is not loud enough. Okay, so you must learn how to shout loud enough, but not not to sound too panicky. It's like you ask for help. It's like, help, I need help. Then you must tell what is the reason that you need help. Is it called prolapse? Is it PPH? And you must be very clear so that everyone can come. Alright. And if you guys know, there's the ting mechanism in our Malaysian hospital. Whenever there's an emergency in labor room, there's one color alert that we trigger. Do you know about this color alert? If you know, type alright, NRHS. Okay, I don't know how to pronounce your name, but the initial is NRSH. You are right, it's red alert. Okay, so this red alert everyone must know. Okay, and every hospital will have this red alert. Basically, this red alert is like you call to the phone or you ask someone to call. You say red alert, labor room 6. Then the operator would call all the specialists, the NS and pediatrician sometimes, and they would need to come because there's a red alert. And of course, you must tell the operator what is the red alert about. Okay. So basically, the first reflex is to call for help, and then these are the other reflexes that I've listed down. Okay. First is for uterine atony. Second is for maternal collapse. Third is for genital tear. Okay. Fourth is for uterine inversion. And then last one, number 5 for mom is the retained placenta. Okay, and for the baby, there's 4. Okay, first one would be when the baby is born flat, means that it's atony. You can feel the tone is poor. Okay, the APGAR is poor. This is an emergency as well. Second thing is a breech. Okay, this breech would be like, usually you guys know what is breech, right? It's like the baby's head is on top and then the body is below, and when it come down, the head is being trapped by the cervix. Okay, later I will discuss more on this. D is of course what Serena had told us, it's called prolapse. And then the last one is shoulder dystocia. Okay. Okay, so we go for the first one. The first reflex, when you guys have uterine atony, what do you all do? Massage. Okay, so is it this kind of massage? Yes or no? Hello, you guys sleeping? All right. Okay, so what massage is this? You guys know? No? Maybe Betty would know. Is this a Chinese massage?
Thai massage.
Balinese or Thai? Yeah, this is Thai. Correct. Thai is where they bend all your. Okay. So this is what we call as a uterine massage. Okay. So there's basically 2. One is internal, means that you put one fist inside the vagina, and another hand is to compress from the top. Okay. A lot of time, doctors will just do this external hand. External hand meaning that you just grip the fundus and they just squeeze on the uterus, and they use just you all can see the arrow in my screen. Can you all see?
Yes,
all right.
Okay.
So usually they just do the external massages from the top. Okay. So when you do the massage just from the top, it will contract as well. But if you can put another hand on the suprapubic to compress it, like the second picture with the green glove, it will be better because it's atony. So when you compress, it make it easier to contract. Plus the uterus will compress better. Okay, and then the bleeding will be less. And if you dare, if you really can do it, then you put another fist inside the vagina, and then you compress the womb from both area. Okay, because if you just do the massage from the top, there's no counter action. You understand? It's the same thing like the Thai massage. You see, the masseur is holding the customer, and then you can see the counter pressure is on the thigh, so that both there's a pressure. Okay, so there must be a pressure and a counter measure to make sure that the womb is contracted. Okay, you're okay? Any questions so far? All right. So what are the medication that you all use that very commonly to treat this atony? Do you guys know? You all can type in the chat. Hello?
Yeah?
Oxytocin, okay, good. Okay, anything else? Okay, so someone asked, Ain Nachiha, how long we should massage the uterus? Okay, the answer is you massage it as long as possible until the bleeding stop or your help have arrived or the senior doctor have come. Okay, all right, so we got a very good list of it. Oxytocin, ergometrine, syntocinon, ergometrine. Okay, so the golden question will be, let's say you are in a cinema, do you have oxytocin with you? Yes or no?
Memory gland.
No. Wow, so many no. All right. You try to mute and answer in the comment, please. All right, so many answer no. Okay.
Tapi dia bagi pip, bagi pressure sikit.
Sorry, can you all?
Okay. All right. So the answer actually is when you're in a cinema, you still have oxytocin, but the oxytocin is not exogenous; it's endogenous. Okay. So one of the thing that survival is like, if you have uterine atony, after massage, you actually can ask the mother itself to do a nipple stimulation. By stimulating the nipple, you can also release the endogenous oxytocin. And then, of course, if the best is, of course, you don't go and stimulate the patient's nipple, okay? All right. The best is, of course, you ask if the baby is active, everything, you put the baby to the mother and let it breastfeed, okay? And then it will also, once the baby starts suckling on the nipple, it will also release oxytocin, okay? It's not my idea, it's not my idea. it's already been there for some time, okay? These are actually from the handbook of midwife, okay? Because midwife, sometimes they need to go to kampong and baby is delivered there, and then they don't have all this excess of oxytocin and everything. And then one of the thing additional is to do a nipple stimulation. Usually is by putting the baby to suck on the nipple, okay? Or you ask the mom to stimulate herself. Alright, you don't stimulate for them, okay? It would be very not so appropriate, okay? Later you can ask Sue, don't quote my name, okay? Alright, okay, quote Betty's name. Quote Betty's name. Alright, okay? Shall we? Any other question you guys want to ask before I go to the second? Sorry, 1, 2, 3. The third reflex? No? Okay. If no question, I go to the next. Alright. Okay. Okay, the third one reflex would be maternal collapse. So ABC, you guys know, right? Not air batu campur. So ABC is what? You guys can type in the comment section what do you think ABC is. Is it American born, Chinese?
Collapse.
Yeah. Do you know what is ABC, guys? Come, I need to test you guys. Airway, breathing, circulation. This one I must consult with Betty. Is that correct? Airway, breathing, circulation.
Yeah, I think so. But
you think so? That one is her not my term. Alright, okay. Okay, you're right. Airway, breathing, circulation. But when the mom is pregnant, there's a slight modification. What modification we do is usually the mother we need to turn to a bit left lateral. Alright? The reason is because the patient is pregnant, okay? So when you turn the baby slightly to the left, and you see the screen, there's this red circle and blue circle that I'm pointing to, okay? So the red circle is the aorta, okay? The vena cava is the blue circle. You can see when the baby is being slanted one side, the vessel become bigger, okay? Main thing you want to increase the circulation. CPR is to what? In circulation to where? Is it to your body? No, it's to the brain. Okay? But to have enough blood going back to the heart to pump to the brain, you need to put the mom 30 degree. So how to put that is you don't go and slant yourself because later you injure your own back. You just slip one blanket or pillow behind the back. Okay? So you reduce the compression for the large vessel. Okay? This is one of the reflex. So if you see a mom suddenly collapse, okay, then you must quickly put in this blanket I think behind, and you see, and then you tip to the left. Okay. Second thing is, of course, this is something that is extra. If you are still junior, you try not to do it. But if let's say your senior couldn't make it, or you're in a public place, you're in district hospital, we can consider do this perimortem cesarean delivery. Meaning that you just cut the mother's tummy from the umbilicus down to suprapubic, and you can see the uterus, and you slowly cut the uterus and you take out the baby. Okay, the most everyone have assisted Caesar before. How many have assisted Caesar before? Put there yes. Comment yes, please. All right.
Quite a lot of doctors here.
Yeah. So when you assist Caesar, is it bloody or non-bloody? You can comment please, bloody or non-bloody?
Non-bloody.
Non-bloody, okay, good. Alright, it's full of blood, okay, because of the uterus, everything, okay? But when you do a perimortem cesarean delivery, mainly because it's a maternal collapse, so the heart already stopped beating, Alright, so usually the general rule is you wait for around 5 minutes and still you cannot revive the mother, then only 5 to 8, then you do the perimortem cesarean delivery. So when you cut open, actually there is not much blood because the circulation has stopped. Okay, so you must quickly take out the baby, then you can continue with your CPR. Okay, one of the things that we can do the CPR is have you seen this movie before, the Matrix? Alright, where this Neo put in the hand into the mother, into the ladies, and then pump the blood from the heart. Okay, this is something that you can do, which is a modified CPR, where you cut open the mother, you take out the baby, then you can see the tummy decompress. Then you actually can put a hand inside, and then you compress the heart pericardium from below the diaphragm, and you compress. Okay, this is one of the way to do the CPR, because when you do CPR, you are basically on external compression, but this one is virtually the whole hand there, and you just compress on do the CPR from the heart. But this is very uncommon. Okay, so these are things that you can try to do if, let's say, you are really the senior couldn't make it. If not, you just keep to the first half, which is to tilt left and continue with ABC. Okay. You guys, any questions so far? No? Okay, I continue first. All right. Okay, so the next thing would be to have this genital tears. Okay, I think genital tears is very common. So a lot of times, doctors are like, "Wow, where is the tear? Is it very deep? I couldn't go in so deep." So the first one of the first reflex that I would tell you is that you can do this anchoring. Okay, can you guys see the tear is here? It's like the epi tear here. Okay. And then you can see there's a blue line here. Okay, so every time when you suture the episiotomy, you will advise to suture from the tip, right? Correct, right? So if you cannot see the tip, what do? You go as deep as possible, and then you suture. You take a deep bite at the end, and then you gently pull down the vaginal tissue until you can see the apex or the bleeder. Then only you suture. All right. The main thing is because vagina is like a tunnel, so it's very deep, and sometimes when you shine your light in, you actually couldn't see inside. So what is the tip is you suture a big bite, and then you drag the vaginal tissue out a bit so that you can see, and you do the other suturing to reduce the bleeding. So this is one thing. Okay, there's a question from Dr. Kaur. Cardiac massage through the abdomen, something new. You did that before? No, I never done that before, because even perimortem cesarean section is very rare. Okay, I had only heard that people did the perimortem cesarean section before. Yep.
Oh, I'm so happy you've never done it before.
Yeah, I'm so happy myself never done it before. But this is what been written in a literature that you can do if in real emergency. All right, where you do the external compression and then you already cut open perimortem, you can just do the internal one, which is more effective in creating the pump. Okay, all right. So yeah, okay. No, it's okay. If you don't dare, then you don't do it. Just continue on the conventional CPR. Okay. Okay, so we continue with our genital tears. Okay, so first thing is you can anchor from the inside and you pull it out, and then you continue to suture so that you can visualize your tear better. Okay, and then the second thing will be to pack. So before your MO arrive, if let's say you still after suturing still got bleeding, what you do is you just pack the area that's bleeding. And if you want it to be more like we call watertight, you can use a glove. You put your gauze, do your pack inside, and then you put a pressure there. Okay, so that it can actually reduce slightly the bleeding. And then another thing is one of the medication that I'm not sure whether you guys have used in your labor room. if you guys have this IV transamine, okay? IV transamine have been recognized to be reducing the bleeding, okay? For instance, they have seen it in this army when they go for war. A lot of war, they have injury and they start bleeding. And when they give IV transamine, they actually reduce bleeding by 50%. So I think the latest, if not mistaken, the FIGO, they actually made that like something that is compulsory, that all the patients that deliver, if they have no, yes, it's tranexamic acid, yeah, correct. So this tranexamic acid is like, once they deliver, they just give, unless patient have certain clotting disorder or they have like previous stroke, so you can give tranexamine to reduce the bleeding, okay? So far in private practice, I've used it for all my deliveries, and actually it does reduce a lot of the bleeding. Okay. Yes, NRSH is tranexamic acid.
Tranexamic acid.
Yeah.
I also have that problem of pronouncing that word. But I want to add something here about tranexamic acid.
Yep.
Low dose of tranexamic acid actually reduce pigmentation on the face.
Oh, okay. So it make you more fairer, alright?
Yeah, that's right.
Okay. But we don't use we don't use primary for that, okay? But I remember there's one patient of mine. She actually is she's actually not Malaysian, and then she does not have this insurance to go for surgery, and not even in government also she doesn't have. So her consulate failed to like provide her the sufficient funding for surgery. So for us, last time I was in government service, so I give her tranexamine, and then she was continuing on tranexamine to reduce her menorrhagia. She has a huge fibroid which need to be removed, but somehow we couldn't do it. And then after a few months of tranexamine, she turned from very dark lady to a very fair lady. Okay.
True. Because in Japan, it's an accidental finding that tranexamic acid actually reduces pigmentation, and now it's very commonly used. Even I use it.
Yeah. Okay. So we have a question from Dr. Lim Chuan Leong. Does tranexamic acid increase risk of DVT? No, it doesn't. It doesn't increase the risk of DVT. Yeah, this is one of the fallacies that some people, they will say that, oh, you give tranexamine later will increase this thromboembolic disease. No, it doesn't. Then what is the thing in second and third picture? This is the modified pack where they put plastic so that it become watertight. So in emergency, you don't have time to look for plastic, okay? So you get whatever that you have, which is like glove, all these things, and you can use that as a pack. How many vials of tranexamine do you use? Usually depends on the lady's body weight, okay? If it's the lady is small size, usually I just give IV 500 milligram. If the lady is slightly bigger size, I will give IV 1 gram. Yeah. Okay. So, any more questions?
The middle thing was a voodoo doll.
No. It's almost the same thing, just that it's a different angle. Alright, so if no further question, we go to the next reflex. Okay. So I think genital tear sometimes will lead to a lot of nightmare in a lot of junior doctors. Usually these are the things that determine, like we don't have junior doctors who mostly like you like ONG or you don't like ONG. There's no like in between. And those who don't like is like, oh, I don't like to see all the genital tears or the bleeding. I mean, is it true for you guys? I'm not sure, okay? Alright. Okay, the next one is a very rare, okay? Very rare is uterine inversion. Usually this uterine inversion is, they say in the literature, is 1 in a million. Okay, if it happened to you, it's 1 in a million, okay? So the main thing is the reflex is not to make it happen, okay? It's not like to solve it when it happens, okay? So to make it not happen, what you need to know is mainly, it's a routine that in every exam they will ask is this control cord traction. You guys know about control cord traction, right? Okay, so yes, usually in multipara, yes, failure of CCT. Sometimes I wouldn't say it's a failure. Sometimes it's it's a misappropriate use of the power. Okay, so you all can see this photo here. This is a CCT in progress. Okay, which is a control cord traction. Okay, there's a hand that holding the cord. Okay, that I call it hand A. All right, and the one pushing on the womb is hand B. Can you guys comment which is an active hand? Hand A, the one on the cord, or hand B, the one on the womb, on the uterus? Sorry, I very used to having layman term. Is it A or B? Alright, we got team B, we got a few of team A. One Serena is team A, the others are team B. Alright, anyone else? Okay, we got one more team A. YYT is team A on the womb. Okay, that is hand B. On the uterus B. On the uterus B. Okay, so alright. Okay, has the comment reply stopped? Okay, somehow it stopped. Okay, so the majority is right. Okay, the active hand is actually the hand B, the hand on the womb. Okay, the uterus. Okay, so a lot of times we tend to pull with the A hand. So when you pull, actually you cause higher chance for uterine inversion. So usually what the hand A would do is that you hold the cord in a very taut position. Taut in Malay is tegang. Okay, so once it tegang, you use hand B to push. So when you push with your hand B, you can see that the placenta will slowly break out from the uterus, and it does not pull the uterus along and causes inversion. So you can try it. Okay, next time if you have any the placenta coming out, yes, you when you pull, you make it taut, then only the active hand is the B that you press the womb down. So this is how you make it separate without pulling out the fundus. Sometimes the main thing is not because you are doing it wrong or anything, but sometimes it's really adherent to the fundus. And then when you pull too hard with the active hand, the A hand, and then the whole fundus will together with the placenta will become inverted. Yes, correct. Tan is correct. You look for all the signs of placenta separation, okay, which is a gush of blood, lengthening of cord, okay. But the CCT mainly you must remember the active hand is the B hand, the hand on the uterus, okay. All right. So if let's say you have an inversion of uterus, what do? Actually, it's very simple. There's no need for all this pump, hydrostatic, O'Sullivan. No, you just put it back, right? How you reverse your you just put it back, right? How you reverse your how you when you have a sock that's turned inside out, you just turn back inside in. So it's like outside in. Okay, it means that you go from the side and then you slowly push to the middle, and with one hand supporting from the top, so that you know that you have pulled in the inverted uterus fully. But when you have this supporting, when you have inversion of uterus, and if it's not bleeding, it's not really emergency, you can actually wait for your senior to come first before you do the inversion back. But if you can do it at the same time, you feel that it's not very hard, you can do it yourself. Okay, but if you are a house officer, better inform your MO first, and then when the MO is on the way and it's keep on bleeding, then of course you must put in back the inversion. Okay, we'll get to MRP later, Tan. All right. Okay, any questions so far before I proceed further? No? Alright. Have anyone seen uterine inversion? No, okay. Alright, the same answer, no, right? Okay. Oh, that's a positive. Positive means what? You have seen uterine inversion, Jax? Oh, okay. So how was it? How do you guys solve this uterine inversion? Can you share with us? Jax Tan and Lim Ki Zhen. Yeah. How was it solved? The uterine inversion? Is it you use all this water hydrostatic, or you use just manual replacement?
What? Sorry, I've never done OBS before.
Yep. Oh, you never done OBS before? Yeah. Yes. So it's a manual replacement. Is that heavy bleeding or just like, okay, so Jackstan and Lim Kizin have seen uterine inversion, and then they call help from MO that was manually replaced, okay? So is it heavy bleeding? It was a disaster, okay? Okay, Jackstan mentioned that it was a disaster, okay? How was it disaster? Is it like a lot of bleeding or anything like that?
Maybe Jax, you can actually unmute if you want to speak. Maybe sometimes it's easier for us.
Oh, okay, all right. I mean, yeah, bleeding around 1 liter, okay. So usually the main thing about inversion is that after it's inverted, when it's reverted back, there was a heavy bleeding because the uterus is not contracted. And then you don't start any oxytocin first, because if you start oxytocin before you push back the inverted uterus, it's very difficult to invert back. So you must push back first, and then only you start oxytocin, then you start contracting, and then the bleeding will stop. The reason is because when it's inverted, it's become atony and it's hard to stop the bleeding. Okay? Alright? Okay. So I will go to the next reflex. Is that okay?
Yeah.
Yeah. Sorry, my slide is a bit stuck. Okay, so when you have retained placenta, this is one of my favorite topic actually. So this retained placenta, actually there's two types of retained placenta, alright? The first type is we call placenta adherence. Adherent meaning that if you can see the picture here, the placenta is adherent to one side of the uterus, which is non-contracted. It's like partial atony of the placenta bed. Okay, this is placenta adherence. Okay, the second one will be trapped placenta. Trapped placenta meaning that the womb, the uterus, is contracted fully. Alright, but the cervix also contracted. So you can see that the placenta is stuck there. It's like it's contracted, but the cervix disallow the placenta to come out. So there's two types actually, but the most common is placenta adherence. Means the placenta bed is not contracted. So what you can do is usually if you put in more oxytocin, then the uterus will contract and the placenta will come out. However, a lot of times the oxytocin didn't go to the area of the placenta bed. So one of the methods that actually can be used in labor room is what we call this beeping gas technique. Where this beeping gas technique is you need to put in a small catheter. The exact technique is to put in a small catheter into the cord, and then you inject some diluted oxytocin, and then you wait for the placenta bed to contract, and then the placenta will come out. However, if in emergency, usually we don't put in a small catheter. You just use a syringe. You poke into the cord, and then you just flush the oxytocin, and you just milk the oxytocin into the placenta, and then it will contract in the womb, and then the placenta will come out. Okay, provided that you have the cord there and it's very stuck. Okay, and then if it's a trapped placenta, actually what you need to do is actually to give something to relax the uterus. Means you need to tocolize. Once you tocolize, the cervix will start to open a bit, and then the placenta will come out. It's just you don't make it contract, you make it relax. Okay. Well, can houseman do the piping technique? Okay. It depends on whether you want to do it or not, but actually it's very, usually I will leave it to the MO if it's not really bleeding. But if like emergency, like for instance, your medical officer is in surgery, Caesar, you will take another half an hour, and you think that patient, the retained placenta is bleeding, then you can consider doing this. But if it's not urgent, like the bleeding is not much, the placenta is just stuck, you can call the second call medical officer, or you can wait for the medical officer to finish the cesarean section first before come to the labor room. Otherwise, you can ask the nurse to get a bit of the, the oxytocin is just like the one after deliver, you have the 40 unit in one pint that will give to the mother, right? You can just take from there 10 cc and you chucho on the cord and you just push in and you just milk it in and you just wait. Yeah, there's no how much of oxytocin to be given. As long as there's some oxytocin that goes straight to the myometrium that, attached with the placenta, it will come out. Okay? So this is for if you really emergency and you really, the MO is not around, or okay, when you are alone, let's say you are in district hospital and then you want to send a retained placenta down to main hospital, like so long, you can try this before you send. Okay, this is one of the technique that I used before, and out of 10 times I use, 9 times it works. And the time it doesn't work, then you have to convert to another one, which is the MRP. Okay, MRP is actually quite simple to use. Okay, basically you need to put your hand in, you sweep it in between the womb and the placenta, and you just sweep and you scoop. Okay, and you do a very gentle scooping motion. Okay, the only thing is that you need to put your whole hand in, so you need to wear a very long glove until your elbow. And for those people who did not know you're doing MRP, sometimes it can be quite scary. Like once I'm doing this MRP and there's a cleaner that walked by the labor room that they saw me doing, he's like, they got shocked. Why? Because my whole hand is inside. It's like, imagine my whole hand inside until my arm is at the vagina. So it's like, it looks very gore. Okay.
Excuse me, even for somebody like.
Okay, it's too gore for Betty as well. Alright, I shall not let you imagine that in your sleep tonight.
So scary. Okay, somebody injecting.
Okay, how does it specifically on artery or on the vein? It doesn't matter. Because the vessel is actually connected to the cord, so you just inject and you just push it in. Do you give analgesic while doing MRP? Well, you can give analgesic before you do it, but usually it won't be that painful if you do it gently. Okay? Yep. Injecting 10 cc. Okay, I answered that question already. Any other question before I move on? Okay, so no question. Alright. So I move on to the next one. Alright. So now we go to the baby. Okay. So baby, actually, basically, you need to attend a course called NRP, Neonatal Resuscitation Program, okay? But these are the few tips that I usually do that without knowingly, okay? First thing is like when you cut the cord, let's say the baby is, what is the thing that you look for when you have the baby deliver? There are two main things that you need to look for. What are the two main things? Can you guys answer? Can you guys, guess what are the two things that you look at the baby? Cry, tone, okay, ABGAR score. ABGAR score is more than 2 already. Okay, tone and cry, okay. Basically, tone similar to cry, okay. Alright. So you can, like I said, there's no right or wrong answer, okay. So the main thing that I look for is usually the color and the tone, these two things, okay. It is worse prognosis if the color is white, pale. Okay, it's worse prognosis if the tone is poor. So if it's pale and poor tone, then the baby is not doing well. Okay, so when baby once delivered, you quickly look at the baby, and then when you need to cut the cord, you actually can feel the pulse. So when you're feeling the pulse, you can see the hand when you're cutting the cord, you're holding the cord, right? You don't like, oh, okay, nurse, you hold the cord for me, I cut. like like going to like cut the ribbon for opening a shop or what. No, right? You need to hold your cord yourself and then you cut. Okay. So when you hold it, you feel the pulse. Is the pulse fast or slow? If it's slow, means that the heart rate is poor. So when the heart rate are poor, you know that you must quickly resuscitate the baby. Okay. So you need to first. You need to stimulate the baby first. So is this the way you stimulate the baby? You hold the baby leg and you slap on the buttock. Yes or no? No. Okay. Anyone saying yes or not? No. Alright. Okay. So we got very good. Alright. So this is not the way. Okay. This is the advertisement last time. Okay. Alright. So the correct way is to actually not to slap on the chest. Okay. It's on the back. Okay. I don't know why the picture here is on the front. And then you can also tap on the sole of the foot of the baby to stimulate, and dry and warm. Okay, these are what we call as initial steps. So a lot of times you can see peds, they will say, okay, initial steps done. So what are the initial steps? They are stimulation, dry, warm the baby. Okay, so after you stimulate, you can see what is the baby heart rate. If its heart rate is poor, you must quickly stimulate, and then you back the baby. Okay, back and mask. Okay, so this one better. The best thing is that you must make sure this back and mask have oxygen flow. Okay, some people they have no oxygen flow and they go and back, and then there's not much oxygen going in. Okay, and then the main thing is you hold the mask on the baby's the nose and the mouth, and then you start bagging. Okay, all right. But if you cannot do this, you don't do first. The main thing is the first treating, which is the stimulate. Okay, and then you must know when to ask for help. Okay, so once the baby come out, if it's dark blue, the tone is okay but just not really responsive, you can try stimulate first. You don't need to call for help. But if let's say it's pale and tone is poor, quickly ask for help. Okay, all right. Yeah.
Can I ask the question? This stimulation, right?
Sorry?
Just by patting the baby on the back, or let's say on the what, can really stimulate the baby?
Again, what is the question? If you really
just by patting the baby from the back or from the
foot, yeah.
So,
yes.
You mean it can really stimulate the baby?
Yes.
Oh, yeah. Is it a reflex?
No, it's not a reflex. It's just an initial step that you do to stimulate the baby so that it will like how to say. Sometimes when the baby come out, it will be a bit poor response or this thing. So when you stimulate, the first step you must do is this: rub the back, dry, warm, and stimulate. Yeah. And then don't panic. Okay.
I don't panic with it, but I didn't
Alright.
realize.
Yeah. Okay. Alright. So if you want the complete one, you must go to join the NRP, the Neonatal Resuscitation Program. Then you can learn more about the resuscitation of the baby. Okay, but the initial one you must know is this 3. Okay, because most of the nurses, they know this if they are going for midwifery. Okay, so the doctors, you should know. Okay, all right. The next one would be breech. So breech, basically a baby when delivering, there's 3 diameter: biparietal, biacromial, and bitrochanteric. Means that your head, the baby's head, your shoulder and your hip bone. These three diameter are the large one. Okay, so when you have a breech delivery, means that the head will come last, and usually the biparietal is the one that's largest. That's why when you have cephalic delivery, means your head come first, baby come first, head come first. It's easier because the other diameters are smaller. But when you have breech delivery, the baby leg come out, the hip come out, the shoulder come out. But then if the cervix got contracted like the trapped placenta, then the baby head cannot come out. So when it cannot come out, what can you do actually? You must release the cervix. Okay, how you release the cervix? We call this a dorsal incision. Okay, can you see here? This is the baby, the hand here, the body, and then the head is stuck. So this is the cervix. So to release the baby head, you do the dorsal incision. Okay, so basically you cut on the cervix so that the baby head can come out. Okay, and then where do you cut? Can you see here in this second picture? The vessels of the cervix is at the 3 and 9 o'clock. So you just avoid any area of 3 and 9. So one of the most recommended are on the side here around 1 and 2. Because in the 12, sometimes it's anterior, sometimes it's near to the bladder. If you cut wrongly or you overcut, you may cut on the vagina and hit the bladder, but usually you won't, okay, because you protect it and you just make a very small incision to release the baby's head. And then this one is breech delivery is very nowadays a bit more uncommon because most breech baby they will go for cesarean section, okay, unless some center they are still like more proponent of breech delivery, then you must be aware. Because when you have breech delivery, the head is stuck there. It's almost the same as shoulder dystocia because head stuck, there will be no oxygen. So by 4 minutes, you must start to do an action. So if your MO is in an operation theater or even in clinic to run up, also it takes more than 5 to 10 minutes. Okay. Seems very easily to cut wrongly, doctor or client. Actually, it's not that difficult to see because when the baby head is already there, you can see there's one ring around the head which is contracting and then difficult to, the head just need to go through that cervical ring, and you just have to make a very small nick to release it. Yep. Okay. So far I've done once. Okay. Very rare we have this kind of situation. It's at the cervix, near 1 to 2 o'clock, you avoid the 3 to 9 o'clock. Okay? I'll type in the comment section, 1 to 2 o'clock. Alright? Avoid the 3 and the 9 o'clock. Okay? Alright. So the main thing is also we want to prevent this from happening. How to prevent is you ask the mother not to push when the os is not full yet, meaning that if the mother want to come and deliver breech delivery, if the os is still 8 cm, 9 cm, she's having very strong contraction, especially those multipara, means that they have delivered a lot of baby before. When they have contraction, they say, oh, I want to push the baby out because I couldn't stand the pain. But you must tell the mother, your os is not open yet, you don't push first, wait for the cervix to fully dilated, then you can avoid this problem of, we call this trapped head in the breech delivery. Okay, question from Anna Karina, do we give local anesthesia before the incision? No. Okay, because the cervix has no pain receptor, so there's no need to give any anesthesia, and it's emergency. You cannot wait until you get the anesthesia and put in and then you cut. Alright. The way to cut, is it the same from Fiona Shaw? The way to cut, is it like the same how we do episiotomy, cutting during the contraction? Actually, when the baby come out fully and then the cervix is just there, you don't wait for the contraction. This is the same like how we episode. Yes, the main thing, you must protect the baby head and then you cut on the cervix. But it's a very small cut, unlike the episiotomy when you do a very big cut, right? This one is just a small nick so that you just release the cervix and the baby head can come out. Alright? And then you must tell your MO you have cut and let the MO repair the cervix. Okay? Don't just cut then, okay, the baby is out, then you forgot about the cut. And the mom start to have bleeding from the cervical incision that you made. Okay? Alright? Yes, you need to suture it back. It won't miraculously patch back. That will only happen in cartoons. Okay? Like I said, you can do it if it's really, really emergency, okay? But of course, when your MO is just nearby you at the counter, please call your MO, okay? It's like this is why I say that it's a reflex that you can do, just that you need to see the situation. For instance, if your MO is just in the counter, you're in labor room, you just ask for help, breech start. And usually breech delivery, your house officer is not supposed to do it independently. Usually breech delivery should be done by at least the junior medical officer or slightly senior medical officer. Alright, so you can do this cut if it's really urgent and your senior is not around. So that what I mentioned is that this is a reflex that you need to do if, let's say, you couldn't get help. Okay, you couldn't get help, or the help you think would be very far away. Alright, for instance, you have a breech delivery in a district hospital. Your general hospital is like 1 hour away. Takkan you want to stand the mother with a stuck baby head there to all 1 away to the general hospital. By the time you reach there, the baby won't survive. Okay, so you must do the cut, deliver the baby. Okay, alright. Okay, so the breech delivery, all these things you can get from the book. That is very routine, everything. Okay, I'm not going to go over that. Alright. Okay, the next one will be a very run-of-the-mill. Every assessment will have this cord prolapse. But the cord prolapse, the main thing that I learned so far, from my experience, is you just need to lift up the butt. Okay. Alright, can you see this one? The first picture, the lady, okay? You just assume she's pregnant, okay? I tried to find a photo for this butt lift for cord prolapse, but I couldn't find any. So I find this yoga photo and I just draw a pillow below it, okay? So basically, if you have a cord prolapse at any point of time, the main thing that you must do is to put a pillow below the butt, okay? Because when you put a pillow below the butt, you can see that the cord actually, the baby actually fall back to fall to the top, okay? And then it it loosen out the cord compression, okay? And then you can see if there's no imminent delivery, you go for Caesar, okay? So all these things that you don't take out your hand or you just leave it there, there's one of the things that you can do, which is you leave your hand there, but the main thing is you lift up the butt, okay? Put the pillow there or put a blanket, anything, and then okay, bring the mother to Caesar, okay? Is that what happened to you guys when you have the cord prolapse? Do you do this, the buttock lifting? Just now there's someone who told me that you have this cord prolapse, right? Is it Fiona? Serena, yes, Serena, okay. And then some people will say that you put in the CBD, you inflate the bladder, all these things. All these things will take time, okay? But the only reflex that is beneficial is to put the buttock up. So when you think of cord prolapse, put the buttock up. Cord prolapse, put the buttock up. Sometimes I even teach the patient. It's like some patient, they have possible risk of preterm delivery, baby in transverse or breech. I will tell them, just in case you go into labor, you have leaking, you must quickly lie down in your car and put a pillow below your butt. So you can see that it's very simple thing that you can do. Ask them not to sit upright, to lie down and put a pillow below the butt. So cord prolapse, butt lift, and then arrange for cesarean section. Okay? Alright. Of course, you must check the baby heartbeat, okay? All these things is in the book, okay? If the heartbeat is not there, then there's no need for cesarean section, okay? Alright, so I'll go to the last one, okay? So the last one is shoulder dystocia, also one of the mill that every doctor should know. So when you have shoulder dystocia, the main two things that will relieve the dystocia 90% of time is the McRobert and the suprapuric pressure, okay? So a lot of people, they would think that, okay, McRobert. So sometimes when you say McRobert, it's a word, it's a big word, okay, it's a name. A lot of people, if you're a doctor, you should know McRobert, but let's say you're in a ward with a junior or maybe medical student, or non-medical student, nursing student, sometimes they don't know, is it McRobert? Then to them, it's like, apa tu McRobert, macam mana buat McRobert? So like they don't know what is McRobert. So the simple term that you must use is put the mother's knee to the chest. That is McRobert. Okay. So when you put the McRobert position, where the mother, okay, you can see this picture. Actually, the mother hold the thigh. Not so simple. Okay. Usually, when the head is there, the mother have no energy to put the hand on the thigh. Okay. So you need two assistants if you can, to push the mother's knee to her chest. Okay, and when you put her in this McRobert position, the hip actually, the suprapubic bone actually comes out and a bigger diameter. Okay, shoulder dystocia mainly is that the shoulder is stuck. If you can see the photo here, the shoulder is stuck behind the suprapubic bone. So what you need to do is two things: lift up the bone, or you push the shoulder down, or you do both. Do both means that you do McRobert when you lift up the suprapubic bone, and then you do the suprapubic pressure. The pressure is not just pushing down. You must see where the baby is facing. Okay, for instance, if I face here, so the pressure must push down and towards where I'm facing. You're basically making the baby crouch. Okay, crouch. If the baby is facing here, you push down but go there, the baby is opening the shoulder, it becomes wider, then the baby cannot come out. So the reflex is that when you push, you must quickly see where is the baby facing. If the baby is facing to the left, you must push down and push towards the left side. So dystocia, shoulder dystocia, main thing is knee to chest, push where the baby is facing. Alright, so this is the two main reflex that you will release almost 90% of the shoulder dystocia. Okay, have you guys encountered shoulder dystocia before? Yes or no? Yes? Wow, a lot of people. Okay. So usually, yeah, this is the run-of-the-mill thing that you will have, okay, and it's very unpredictable. Not just big baby, sometimes small baby also can have dystocia. Wow, Fiona Shaw said yes, and is followed by PPH. Okay, what is the reason for PPH? Fiona, would you like to share with us? Okay, we wait for Fiona's comment.
While we're waiting for Fiona's comment, what is PPH?
Yeah, so PPH is a postpartum hemorrhage, mainly like heavy bleeding or uterine atony. Okay, so this one is atony, so it's unrelated to dystocia. Okay, mainly the dystocia is the stuck shoulder, and you need to release the shoulder, and the atony is maybe the womb itself just wouldn't contract. Okay, yeah. So sometimes it's a combination of emergency, so there's a few reflex that you need to know. Okay, all right. Okay, I think this is the last reflex that you need to know. Okay, you guys have any question about this reflex that you need to know? Mainly, you must keep it very simple. Okay, if you emergency, you must memorize. McRobert is for exam purposes, but for real life, knee to chest. Okay, even if like me, if I know that my midwife are very experienced, I will just say knee to chest, so that it's very simple. And then even you wake up 3 a.m. oh, suddenly dystocia, knee to chest. You know what is knee, you know what is chest. When I said McRobert, some people say, oh, McRobert. Suddenly they couldn't click, Alright, so make it very simple. Okay, Jack Stan asks if McRobert and suprapubic pressure fail to deliver baby, any other maneuver, or there is a lot of other maneuver. Okay, so the next one that I would go in line to use is to deliver the posterior shoulder. Means that you can see this photo here in the photo B. After you have put suprapubic pressure, this hand is already down, but this hand is not out yet. So you can slip your hand below the baby head and lift up the posterior hand. So you can see if because I'm using the screen. So if you push the shoulder side and you lift up another hand, the diameter becomes smaller. So it's easier to deliver. So this is one of the tricks of delivering the posterior shoulder. And then you can you don't need to be so afraid. Some of the baby, their joints all are very flexible, and even if you just pull a bit, they will just go back by itself and they will heal very well. A lot of times people don't dare to do a lot of maneuver because they were scared. They were saying that, oh no, later the baby hand breaks, how this thing. Okay, But you must understand, dystocia meaning that the head is out but the shoulder couldn't come out. If too long, the lead to asphyxia and the baby may have this cerebral palsy and hypoxic ischemic encephalopathy. All right. So I mean, you must go by what you need to do. Okay. If you think that you can have some time to get your senior, you get your senior. Okay. Do you mind repeating the part of lifting another limb again? Can. All right. So basically, can you see the arrow on my screen? Can you see the arrow? All right. So here is where you put the suprapubic pressure, and then your hand, another hand, after you're doing the episiotomy, you go from the back and you can feel the baby's this axilla. Then you scoop the baby's hand and lift it out. Means you scoop this hand and you lift it out from the vagina. Then you can see that once you lift one hand out of the uterus, you can see the whole diameter become smaller. Can you imagine, like, first, okay, I go a bit further. First you make it like this, so the diameter is still big. So when I hook up this hand, it becomes even smaller. Then the baby can come out easier. Mainly is you will make the 180 turn. Sometimes the baby doesn't turn, but your main thing is to make the diameter small, your shoulder small. Okay. Episiotomy usually needed, okay, because if you don't do episiotomy, the vagina is sometimes very small, you couldn't go in. So you need a better view, so you do the episiotomy. But be careful because the baby's head is there, alright? So you must really protect the head when you do the episiotomy. Okay, so okay, alright. Okay, Kai is very happy with the answer. Okay, you are welcome. All right. Okay, so all right. Any more question about this dystocia? Mainly, you don't need to worry about all this posterior thing. I think for my experience, usually these two will just sort out a lot of this dystocia. And then if you really doesn't know these two, then you need to learn it out. Okay, all right. Okay, so if no further question, I go in all four position, or that one you can do, that one also. But I would just recommend you learn these two, and the all four maybe later. All four will be just like this one. Okay, this is all four. Means you put the mothers in the sort of like backward position, and from here you deliver. So this one is the same. You deliver the posterior shoulder first. Because posterior, there's no obstruction from the suprapubic bone. All the method that you use, you must understand how it functions. Then you know whether you're doing it correctly or not. A lot of times you just follow McRobert, suprapubic pressure, but what does it do, you don't know. Just like suprapubic pressure, you must make sure you press to the direction of where the baby face is facing. You must know the reason behind it. Okay, another question is, how do we do episiotomy, doctor? Any specific location? Episiotomy would be the medial lateral. That one, medial lateral. Usually, I would do on the right medial lateral. So if let's say this is the vagina, and then I would just cut to the 6, 7, 8, around 7, 8 o'clock. MLO meaning what? Or you want to type Milo? You are hungry, is it? Or you want to belanja me Milo? What is MLO? Oh, okay. Haha. So it's not Milo, okay. Alright. Is it middle, lower, something? Alright. Okay, we wait for Sophia Ashikin to define us what is MLO. Medial lateral oblique. Okay. Oh, that's very cool term. Medial lateral oblique. Okay, correct. Okay, another tips about cutting this MLO is I would say 7, 8 o'clock. Okay, easier using the clock. Okay, sometimes you use too bombastic word, you are just like too doctorish. a bit snobbish, alright, but okay. But you need to know the term if you're with a doctors, of course. Your senior giving assessment or thing. So usually when you cut, you don't just really cut oblique, you go slightly higher a bit. Alright, better to be around 8 o'clock. Because when the vagina wall is being stretched, you cut 8 o'clock. When it's unstretched, you go down to 7 o'clock. Okay, so if you cut 7 o'clock, you will go more towards 6. So then the tear will go down more to the anus. So one of the tips is you cut more towards 8 o'clock. Okay, Sophia, she can share the Milo, the medial lateral oblique. Okay, all right. So okay, so can we move on? All right. Any more question? Okay, there's an emoticon there. I couldn't see well, very small. It's supposed to be a ghost, is it? Or is it a crying ghost? Oh yeah. Don't cry. Okay, so alright. So in a nutshell, not really a nut, a big coconut shell. So here are all the reflex that you need to know. Okay, first thing is all the patient ask for help. Okay, if it's atony, you massage. If the mom is collapsed, you left tube, do ABC. Genital test, you pack, do a anchoring suture. Inversion, you put in back, outside in. With the retained placenta, you can try to fit the cord, or then not, you do the MRP sweep and separate. If it's a flat baby or atony, you stimulate back and mask. Reech, you cut the cervix, not at 3 and 9 o'clock. Cord prolapse, you lift the buttock up, okay, and then prepare for cesarean section. And if it's shoulder ystocia, knee to chest and push the shoulder down, which is the suprapubic pressure. So all these things, if possible, if you are still junior or very new, you can try to imagine one by one what happened, then what you need to do, what happened, what you need to do. So when you imagine it every day, then you got mental preparation, so that whenever it happens to you, it's like a bit natural, you know already what to do. And of course, you must ask for help. And then when the help is there, you ask for help. You don't be a hero, okay? Just like what I mentioned the first slide, you don't be a hero, okay? First rule of medicine is what? Don't be a hero. No, actually the second rule, okay? The first rule is your boss is always right.
Do no
Okay.
harm. No harm.
So you listen to your senior. Yes, don't know how, okay? And then don't be a hero, okay? Always ask for help, all right? Always ask for help, okay? All right. Okay, any other question that you guys want to ask? Any burning question? Ask now or forever hold your silence. Okay, I'm joking. You can ask your other senior as well. Okay, if you have any question you want to ask me secretly so that no one else knows, you can DM me at my Instagram at Gynae Penang. But you'll be charged. I know I won't charge you lah. Okay, all right. Okay, and then if you want very comprehensive details, you can actually go to one of the website, one of the society we have, which is OGSM. Okay, OGSM is not orgasm. Okay, OGSM is Obstetric and Gynae Society Malaysia. All right. Okay, ICOE is for our obstetric emergency. Okay, intensive course in obstetric emergency, ICOE. So you can Google OGSM ICOE, okay, to get to the website, and you can maybe join us in the course and you can train better. Okay, all right. Thank you everyone for listening to me. Okay, just try to share a bit of my experience. Okay, not really a very good sifu, what I'm so learn from everyone. Okay, all right. So yeah, these are the few small reflex that you all can learn up. Okay, that yeah, in case of really emergency that you are alone, yeah, then you'll be useful. Okay, all right. So okay, yeah, it's a revision as well. Okay, you must keep revising. Okay, for me, I'm so revising every day. Okay, because sometimes hopefully not all emergency come to me, but when it happen to me, it's like, oh, good old times. I had a cord prolapse last month. Last month, actually, she's a wife of a doctor as well. So the doctors.
Oh my God!
So the doctor is like, the doctor is the MO as well. Like, what to do? It's like a bit panic. I said, no, it's okay. Just lift the buttock up, go for Caesar, and the baby come out crying very nicely. No other problem. Okay. All right.
I think.
So thank you, everyone. Thank you.
Yeah, you're all welcome. Let me just say a few words before we go. Thank you very much, Kapin. I am so happy today that the interaction with this our viewers was fantastic. They have never been so responsive in any of our talks before, so I'm very, very happy for that. I'm also very happy that many of them seem to be already in practicing. Means they are already in practice either as a house officer or as a doctor. And I'm pleased to say that Beating Hearts has already submitted again to MMA to award CPD points. So hopefully that will be approved so that in the future we will actually have our webinar. Another thing is that yes, it is very difficult to be very confident during an emergency. It comes with practice, it comes with experience. Some people are better than others. Confidence is good, but never be overconfident. And again, Dr. Low has said that practice in your mind when you don't have the cases. That is extremely, extremely useful. I do it all the time. I do it for preparation for interviews, for vivas, for emergencies. I imagine scenarios in my mind all the time. It might not be exactly the same, but it helps. And the other thing I would like to say is that thank God there are not many emergencies, and yes, we don't pray for it, but always be observant of just don't judge, but what they do, always learn. So when be observant of everybody, means other MOs, other house officers, see how they handle situation and learn from it. So with that, I think thank you very much for tuning in. Next week we have another topic, emergencies in diabetic emergencies by an endocrinologist. And have a nice week ahead. Bye, guys.
Okay, bye. Happy New Year.
Happy New Year.
Thank you everyone. Thank you everyone for listening.
Thanks, Kapin. See you again.
See you again.